Good evening, everyone. Welcome to the webinar titled 3D Printed Surgical Guides in Implantology Planning to Execution, being hosted by DC Academia and INsight CBCT. This will be presented by Dr. Swapnil Pande, who's an implantologist and heads the implant division at Dental Ceramists India Pvt Ltd, which functions as the first CAD-CAM lab of India at Bandra, Mumbai, and by Dr. Ajay Nayak, myself. I'm the Chief Maxillofacial Radiologist of INsight CBCT, and we handle 7 CBCT centers throughout Bombay and Pune region. So we have all studied about radiography and imaging, and we know that now it has progressed on complex scans like CBCT scans and CT scans. So these give us a fair feature of the jaws that are there and the maxillofacial region. But always we ask what comes next. What is the course beyond this complex scans, especially in the context of implantology? So the next step that the implantologists consider is utilization of precision in the various situations they come across, in the various clinical situations that mandate absolutely precise manipulation of the tissue and to get tangible results which will give efficient functional modalities to the patient in the form of chewing. So in this case, in implantology, the factors that handle this precision is angulation, and the second one is the depth of the implant that goes within the jawbone. So for that, the next step is CBCT derived surgical guides, which have been in vogue for the past half decade or so. And let's go about seeing how we go about dealing with that. So what exactly is a guided implant surgery? It simply means that it is a precisely planned custom-made surgical template used for the placement of implants. So earlier, we used to have vacuum pressed acrylic guides. This were fabricated exclusively in the laboratory. Whereas now we have stepped onto 3D printed guides, which are derived from CBCT scans and from other technology advances that we have recently got about. This is how vacuum pressed acrylic stents were earlier fabricated. These were made in the laboratory and were primarily based upon the clinical experience and were quite anecdotal. There were a lot of flaws that used to be transmitted from this laboratory setup into the clinical setup. Precisely, the angulation could be a little vague and the depth could never be ascertained using these vacuum pressed acrylic stents. So the other thing that was devised was the limitations that were there in the in-house or the vacuum lab processed vacuum stents. This was usually made by the technician who was not trained in implantology. There was no depth or angle control, and these were found not to be precise at all based on various studies in the literature. The stability of the stents was also suspect, and the material used was not biocompatible, being a resin which used to generate a lot of heat for the patient when worn. The most biggest advantage that these stents, however, had was they did not require any special surgical kit. Compare this with the CBCT derived 3D printed stents. These are always planned by either a radiologist or an implantologist or both sitting in conjunction. There is precise depth and angle control. The resin used is absolutely biocompatible to be used intraorally, and the design of this entire guide is based upon the final processes that will be placed on the implant, which is why it is definitely a prosthetically driven procedure which keeps the end objective in mind. And this is found to be absolutely precise in our clinical experience. The disadvantages: this requires a special surgical kit which may not be already present in the armamentarium of the implantologist. So what are the indications that we can use the 3D printed surgical guides for? These are the indications that we can use it more commonly when there are a lot of implants being placed adjacent to each other, when there is vital anatomy which is there, or there is adjacent teeth standing next to the edentulous areas, if the bone volume is not sufficient, or in situations where the implant position is absolutely critical to the restoration, and if the patient chooses to go in for a flapless implant placement, or previous trauma or surgery which may have altered the anatomy in that particular region. So this is how a CBCT derived 3D printed guide appears. We can see that this is how the implant is then placed, and this is immediately after the placement and the guide is removed. So this is how flapless and bloodless the whole procedure goes about. So let's go about seeing how we arrive at these 3D printed surgical guides. So to simplify the workflow, when a patient comes to you and based on the indications, if you have taken the call as an implantologist to utilize a 3D printed surgical guide, the first step after clinical examination would be to obtain a CBCT scan. The second step would be to obtain an intraoral scan using an intraoral scanner. Then a third-party software will be used to use the data from the CBCT scan and the intraoral scan, and these will then be merged together and a virtual planning will be created on this third-party software. And finally, this third-party software, once the virtual planning is done, it will help us design the guide. This guide design is based on a lot of sound fundamentals, but once the designing is done, that designing is then translated into a particular file format, which is called as a STL file or a stereolithographic file, and that will then be sent on to a 3D printer. Now the 3D printer understands the language only of STL files, and that's why we need to generate these STL files, and that STL file is then transmitted on to the 3D printer, and the 3D printer then prints out the guide in 3 dimensions, and that's how the guide gets fabricated. This guide is then obtained and provided to the implantologist. The implantologist then uses this guide intraorally and then goes about with the implant surgery. So we'll be not discussing the implant surgical aspect too much in detail today. Rather, we will focus on how to go about this particular workflow until the point of the guide fabrication. So both these presentations will be done simultaneously by me and Dr. Swapnil, my colleague. And we will start first with the CBCT scans and the intraoral scans, and then the actual virtual planning and the merging of these scans, etc., will be shown to you live by Dr. Swapnil. So let's go about dealing with the workflow of the CBCT scan. So the CBCT jaw scan, this is a particular patient that we have now. So this patient's mandible has been scanned, and as we can see on the right side, the right mandibular or the fourth quadrant, we can see that the 5 teeth are standing. So we have the first and the second premolar, and there is a gap in between these 2 premolars, and there is an edentulous space distal to this premolar as well. So we would like to, in this case, plan an implant in the 4-6 region or the mandibular first permanent molar. So let's go about having a look at the CBCT scan we had done for this patient, so as to evaluate what we're going to look on to the CBCT scan. So usually CBCT scans give images such as these, or they may be slightly different in the visual format, but ultimately the information that comes out is usually uniform in most of the CBCT scans. We have this section, which is also known as the axial section, and in this we can see a cross section of the mandible. Then we see a line which goes along the shape of the mandibular bone. This is called as the arch setup, and once we take this and if we straighten it out, we get this panoramic image of the same mandible. So we can see the panoramic image. Now we can see that there is a scale on this arch setup as well as a corresponding scale here on the panoramic image. Then we see these green lines. Now what essentially are these green lines? These are the slices. So what do I mean by that? Suppose that I'm going to take a knife and I chop through this first green line. All the tissues that are going to come in this section of the jaw will be seen in this particular slice. We can also correlate that with the scale which is there here and with the scale which is there here. So this is how the slice is. So in this case, we are going to evaluate the sections from this region to this region. So this is the area that we are assessing in that, and we have the buccolingual sections. Each of the section number is seen in this. And in this, we evaluate the buccal cortex, what you can see here, and we evaluate the lingual cortex. So this is how we evaluate the cortical thickness, the cortical contour, and we have also traced the mandibular canal by putting color within the canal. So this canal also appears in slices as a red dot. So this is how we can see this is the first premolar, this is the second premolar, this is the edentulous space. We have done certain measurements here in the region, which is the exact edentulous gap present in between these 2 premolars. So we can see that the crestal width is about 3 millimeters and the height of the bone is about 11 millimeters. And this is the area where the right mental foramen is seen exiting from the buccal cortex. So the buccal cortex is this side and the lingual cortex is this side. Right? We also assess the trabecular pattern. The trabecular pattern seems to be fairly regular throughout the area. But this is not the area of interest. This was just an illustration for us to understand how to look at this CBCT scan. Now we shift our focus to this image, which is the CBCT slices of this particular molar region, the edentulous space distal to the second premolar. So this is the second premolar, and we'll be interpreting this like this. This slice, this, come up here, and this is how it goes. So we can see this is a lingual cortex and this is a buccal cortex. The buccal cortex is slightly thin, immediately distal to this premolar, but as we come more towards the first molar space, we can see that the buccal cortex is quite uniformly thick and it is showing a regular contour. There's not much of a dip. There's a slight curvature here, and the width of the crest in this region is about nearly 4 millimeters, but not completely so. And the height of the bone appears to be about 12 millimeters. And as we can see, the trabecular pattern also seems to be fairly regular. And only distant to this area, it starts becoming a bit sparse. The buccal cortex also then starts falling in towards the lingual cortex. And we can see there is this thickening here. This is called as the buccal shelf area. And this is a part of the external oblique ridge which is seen. And that's how there is this cortical thickening noted here. So this is the area that we are now going to look at to go about fabricating a guide or placing the implant. So once we have got the CBCT scan, what essentially comes out from the CBCT scan is the DICOM data. That DICOM data will then have to be transmitted to the lab which is going to fabricate the guide. This DICOM data can be transmitted digitally through the internet. It can be transmitted in the form of series. It can be transmitted in any form that digital data can be transferred in the form of pen drives, CDs, etc. But the easiest way that we find is that it can be transmitted through the internet, and the lab receives it immediately within half an hour or an hour of the scan, wherein the DICOM data is completely downloaded onto the laboratory computer. So the next step is to clinically scan the patient's oral cavity. Now, why do we need this step? So essentially, when we have the CBCT scan, we get the DICOM data, that is the format in which the CBCT scan is obtained. Now, this DICOM data is going to be the basis onto which we will virtually plan the implants. Now, that sounds very nice when we do the virtual planning, because the radiologist or the implantologist is going to do this planning on the computer. But then it's not so easy to transfer the same planning into the patient's oral cavity in the clinical setup. So that's where the role of the surgical guide comes in. So what we do is we then scan the patient's oral cavity as well, and then we transfer these two scans together and we try and merge them. So then whatever is the scan data coming out from the CBCT scan is used as the basis for the planning, because that's what shows the tissues inside, not at the surface, but right within the bone. Whereas the intraoral scan is going to show us the tissues which are there on the surface. So that's how we can transfer things which are there within the bone to a tangible three-dimensional object which is there on the surface, which is what is going to be done by the Exoplan software. But right now, let's deal with the intraoral scan. In this case, we have used the MEDIT scanner, because that's the scanner that we use in our laboratory, and it is one of the leading scanners that we have from Europe. It is one of the easiest instruments that is devised. It is very quick and efficient, and I can tell you this from my personal experience. Let's have a look at it, and then you'll understand better as to what exactly I'm trying to tell that. So here's where you can see that this is the actual clinical picture, and this is what the scan is coming about. So essentially, this is an instrument which appears just like the light curing device for a composite resin, and that is how light it is. All that has to be done is be moved over the area that we are looking for. In this particular case, we were looking for the maxillary anterior region where a single tooth was missing, the central incisor, and we were trying to scan the area digitally. So as we can see here, it shows certain blue or purple areas, which tells that that area needs to be scanned more. And as the probe is just moved back and forth, left and right, this is how the whole area gets scanned. Once this area gets scanned like this is now converted into digital data for the software of the MEDIT scanner. And this MEDIT scanner software can then again be transmitted to anywhere in the world using the internet, because this is in the digital format and this can very easily be transmitted, right? So we can see now the same patient and abutment fitting has been placed, and now we're trying to scan that as well. So again, the process remains the same. We just take the scanner probe and place it very near to the tissues, and this is how it goes about scanning the area. And this is as simple as this. This can be easily done by any clinician who has used it just once and does not require any very significant expertise to be mastered upon. So this is the opposing jaw now. We're also going to scan the opposing jaw because this helps us determine the occlusal relationships of the maxilla and the mandible in this particular patient. So again, the same way, we just go about holding the probe very close to the tissues, and you can see the light patterns coming here, and we go about scanning that. Those are the areas that need to be scanned a bit more is what the software tells us. So we go over that, and this is how this goes about taking data or information from the patient's actual oral cavity and transferring it into the digital format. So this is very absolutely crucial that we get all the data in the digital format, because digital format is the way, the language that the Exoplan software is going to understand, and this will be then correlated and help us merge the intraoral scan with the CBCT scan. Dr. Swapnil will be demonstrating to you very shortly this whole procedure once this scan and that scan is generated. Now this is the patient's jaw in occlusion. So the occlusion relationship is then determined, and this is how, once the patient is asked to bite in occlusion, we just go about moving the probe in the vicinity of the area that we are looking for, and that helps us easily get a scan and shows us the occlusal relationship. All this data is fed, all those details can be fed in, and it is very simple. It's an absolutely efficient and simple procedure, and see, this is how it appears. So that's the way the intraoral scan is done using the MEDIT scan. So the next step is, we have got the CBCT scan, we have got the intraoral scan, and we then go on to the Exoplan software. Now this Exoplan software is again a patented software which comes from Europe, and we have this software for exclusive license to Dental Ceramists, and this is the software which is going to now merge both the CBCT scan and the intraoral scan. And once the merging is done, now I request my colleague Dr. Swapnil to show the merging, and he will show that once the merging is done, how exactly we are going to go about with that. So, Dr. Swapnil, I request you to now show the merging part.
What we are seeing on the screen is a database page of the software. It is the opening page of software where we input all the details what we have and what we are going to do to the. We are going to tell this to the software. So we will write the name of the patient over here. So the patient name was Priyanka. We are going to plan an implant on 4/6 region. So we are going to plan an implant on 4/6 region. We are going to print a guide in PMMA material, so that we will select the 3D print and PMMA material over here. Okay, so after we have antagonist scan, so we'll tell the software the maxillary is antagonist. So after entering all the details, we'll go for the implant planning stage. So after filling all details, we'll go to the planning stage. So basically there are two input requirements for the software. First is the intraoral scan, and second is the CBCT data. So we will load the intraoral scan of the patient first. So we have mandibular scan. So software will tell you which you have to load scan. So lower scan we will load mandibular, then antagonist scan upper jaw. So we'll load upper jaw. After that we will be loading mandibular CBCT data of the patient. So here we will load the CBCT data of the patient. So all the requirements are fulfilled. So all the input details are given to the software. Now software has inbuilt DICOM slider. You can see it on the screen. So this is a DICOM slider where you can check the details in the DICOM data. So you can increase the threshold and check for the bone, clearer bone. You can check for the enamel and dentine. So you can remove the bone. Now you can check for the teeth, enamel, dentine. So these things you can check. So where it is very important in the case of the full mouth cases. So you get to know where the strong bone is and which where you have to engage your implant. So you can see the lower mandibular, this area is as strong as your root of your teeth. Okay, so that's why this slider is important. Now after checking all the DICOM data, you will move forward. So this is the axial, changing axial direction. Generally, it is not needed if patient has kept his head straight while taking a CBCT scan data. Otherwise, you can change it from here. Okay. If patient has tilted his head, then only you can do it. Okay. Then only do you have to do it. Now this comes the most important stage of the software, which is registration, means merging of the CBCT data with the intraoral scan data. So generally this stage is done in two steps. First step is a manual alignment. Second step is a auto alignment. So I will show you now how we will do the manual alignment. First we will clear the DICOM data first. Now you can see the teeth enamel on both the datas, in scan data as well as iOS data. So we'll mark the three common points which are common in both the data. Okay. So I will be marking first here and then here. How much far you place the point, that much good merging you will get. So try to put this point as far as away from each other. So now you can see the teeth data is merged to each other. So this is a manual alignment. Now we'll go to the second step of alignment, which is auto alignment. So in this stage, the software will automatically diagnose the common area into these two data and merge it into each other more perfectly. So now auto algorithm of the software is going to work. So you can see how software has the snap found out the common data and snap the model into each other. So you can see this color grading. So this color grading will show you the accuracy of your alignment. So this is a little bit imperfect alignment because you can see there is bone inside. So we'll go back and again do it at once. So what we will do is cut the CBCT mesh over here. Now we'll start again the best fit. So this is much more perfect data alignment. Okay. So we'll accept this data alignment and move further. In this stage, we will convert your 3D data into 3D panoramic curve. Dr. Ajay has already explained this. Here in case of this stage is important if you are going if you want the processes before your surgery proceeds. Okay, so here you tell the software which kind of processes you are going to do. So we'll be using stock abutment. Now this is the most important stage where we mark the most important landmark, which is mandibular now. So here I'm marking mandibular now. So after I mark mandibular now, the next stage is a virtual crown placement. This is important for prosthetic placement of implant. So this virtual crown will give me idea about the angulation of implant in relation to the prosthetic crown. So I will adjust the height and size of the crown over here. After adjusting future crown, now the step of implant planning. So what we have here is libraries of different implants. So you can see Bicon implant, Bioline implant. So these are the files of the all different implant which is available in the Exocad software. Okay. So whatever the company of implant you are going to choose, you have to tell the software. So I'm planning this case for ostium implant. So I will get the ostium libraries. So ostium TS system, which is most common in India. So I will tell the software this library I want. Now I have different sizes of the implant and different heights of the height of the implant. Okay. So in the molar, as company recommendation, I can place 4 or above 4 diameter. So I will try for the 4 mm of the diameter. N number of trial I can get. So this is a virtual planning. Whatever the changes has to you, how much time you uh, give it, give for the planning, that much your surgery will be smooth. So I can plan for, I can try for n number of widths. So this is 4, this is 4.5. So according to your choice, whatever the operator's choice, whatever is suitable for you, so you can take that width. So here is 4.5, which is I think which is suitable for this case. It depends on operator to operator. Okay. Now height, I'm going to choose for a height 10 mm. So still I have some space. So 11.5. Okay, good enough. So for this case, I'm going to plan for 11.5. If I go more deeper, 13 mm. So now you see, this is a safety margin. The red area you see surrounding implant is a safety margin. So if I select the 13 mm, then I am encouraging into the safety margin of a lingual now. Sorry, mandibular now. So this is not an appropriate site for this case. So 11.5. Okay, good enough. Now, according to the prosthetic crown, I see the angulation. This is a crown, final crown. So I'm going straight inside the crown. So my implant is pretty straight. Check for the bone size all over the implant. So after you are happy with the placement and angulation, you can proceed to next stage. So once you are happy with the direction and angulation of the implant, you can proceed to next step. So next step is a selection of kit. So whatever the kit you have to provide, you have to fill this detail into the software. So I'm going to use, as it is ostium implant, and ostium company has a wonderful kit called ostium one guide, and I'm going to use same kit. So here I will select the ostium one guide kit surgery. Okay. After selecting that, the software will give me a detailed planning report. Generally, it is advisable that planning should be done by operator only, or that means by doctor only. But in case sometime the planning is done by a technician or someone else, then planning has to be approved by the doctor. Then only you can proceed for the implant manufacturing or guide manufacturing. So software will write all the details whatever I have done till this point, and give me a detailed written report of it. So you'll get the report like this. So the patient's name is Priyanka, and this is all details. This is OPG. This is plan implant position. This is nerve position. This is the implant information. Uh, this is the angulation. If there are two implant, it gives angulation to each other and all other details. This is cross sectional area, how it will look in each cross section. So operator has to approve this planning if he is not doing his own planning. Okay. After approving it, we'll proceed to main step, which is guide manufacturing. So these are the parameters for operator to set. So these are the parameters for the printers. So we'll not go deeper into this. In this stage, we will block undercut according to path of insertion. So we will select the path of insertion and block out the undercut. The software will block out all undercuts for this direction. So these are the undercuts. and software will automatically block this undercut. So now you can see all the undercuts are blocked. In next stage, we will mark the extension for the guide. So how much, what should be the extension of guide according to your preference? We will mark the extension. So I have given this extension for guide production. So now you can see, according to extension, your guide is ready. If additional window previews window we have to put, we can put. This window will help us in determining final fit of the guide into the patient's mouth. So you can see this is window. This window will help us at the final stage during surgery if guide is placed properly into the patient's mouth or not. So now we have a soft copy ready. So this is a final soft copy of your guide. So now we have a soft copy ready for the final surgery. We have to 3D print it and proceed for the surgery. So next step for this procedure will be explained by Dr. Ajay. Dr. Ajay.
Yeah, thank you, Dr. Swapnil. So as we just saw that Dr. Swapnil in the Exoplan software integrated the CBCT scan and the intraoral scan both in the digital format. These two scans were merged and then he did the virtual planning. Now, just as a disclaimer, I would like to say this was not the perfect virtual planning, but a mere overview for you to understand the process. The actual process does not happen in 10 minutes like that. It takes a lot of time for the implantologist and the radiologist to sit and perform the virtual planning. So the entire process of the virtual planning usually takes about 45 minutes to an hour for just 2 or 3 implants. If there are more implants, it takes longer. And then that's how. So the diameter that was put was just now 4.5 millimeters, though the ridge size was actually less than 4 millimeters, because that would be done in the proper manner. But this was just now demonstrated to you how it could be placed. All the dimensions, etc., were not very accurately done right now, but just as an illustration for you to understand the process that is undertaken. So once the virtual planning is done as per the requirements of the implantologist, and like Dr. Swapnil mentioned, the software generates this report, and that is then sent across to the clinician. And once the approval is done, then the guide design is also performed. Once the guide design is made, now the guide design also Dr. Swapnil did so efficiently and so fast, but in actual process, it takes much longer because he uses a lot of fundamentals and principles into incorporating the guide design, and it's not just done so fast. There are a lot of principles involved in that. We're not going into the theoretical aspect today, but we have just shown you a brief design that could be generated from the software. That's how it appears. Once this guide is designed and then approved by the implantologist, the next step is to generate an STL file. Now, what exactly is this STL file? STL stands for stereolithographic file. Now, that is the format which the 3D printers understand. That's the language that the 3D printers understand. So like if we have normal printers which take printouts on paper either in black and white or in color, they understand the language which we can use either as a Microsoft Word or an Excel sheet or stuff like that. So the format that is required here for the 3D printer is an STL format or a stereolithographic file. So this is the 3D printer that we have used, that is Slash, and in this 3D printer we have now fed the STL file which has been generated from any particular case. And now this is a case we have done earlier, and then this is how the surgical guide gets printed. Now if you notice in this, there is a resin die and that goes on getting sequentially layered. Now that can be seen if you can see closely on this picture. there are these various serrations that are there because this guide was made layer by layer in a sequential manner, and it takes some time to build it up in 3 dimensions. And finally, when it's ready, this is how it comes out from the 3D printer. And once that is done, that is then placed upon the study model and finished off in a smoother manner so that all the rough edges are taken off and all these serrations, etc., are removed so that this guide can fit perfectly inside the patient's oral cavity. But right now, this is fitted only on the model. Then this will be tried onto the patient's oral cavity. So this is how finally this particular guide, once it was printed and then finished off, it was then inserted into the patient's oral cavity. Now I'll show you one video of how this was done. So the same guide I will show when it was being placed inside the patient's oral cavity. So you can see, as Dr. Swapnil had mentioned, that we check for the fit. So in this patient, anterior teeth were standing. So this was then placed inside that. And then the guide is placed onto the residual alveolar ridge. You can see the fit around the buccal flanges and the palatal flange. And we can see that the guide is sitting in very comfortably without any rocking movement. Because that is absolutely crucial, given that surgical drilling will happen through the guide. And for that, we would want the guide to be very stable and precisely seated without any movements. This is how the guide looks in the oral cavity. The next step is to make the punch cut or using the punch drill over this guide. So this is how the punch drill is taken and it's passed through the guide, and then it goes about creating the punch cut onto the mucosa over the residual alveolar ridge. You can note there is a cylinder there attached to the drill. That's a modification to the normal surgical drill that we have. So this is why it requires a special surgical kit. So you can see again, once again, I will show you this, where the drill is placed in the oral cavity through the guide, and then the punch cut is made. Once that is made, we would like to evaluate the punch cut as well. So let's evaluate the punch cut that has been created. This is how it appears. Just a very small bleeding spot, which can very easily be blotted away. The entire surrounding tissue is not traumatized. So there is much better scope for healing, faster healing and better healing. So again, I would like to inform, if you have any queries, please type it in the chat box or onto the WhatsApp group that has been created, and we will try resolving those at the end of the webinar. Now this is the illustration of a different case that we had undertaken. Now this is a single edentulous area in the mandible. Now this is a mirror image that you can see. This is the patient's lower jaw actually, and this is the left side of the patient's mandible. We are looking at a mirror image. 236 is missing here, and this is 37. And we can see that this is how the guide was in position. In this particular guide, we also used a metallic seal, which may not be used always. Then this is how the implant was maintained in place after the surgery. Now this is how the virtual planning was done on the computer. This is a safety margin that is there, and this tooth was planned such that it was about 2 millimeters away from the superior cortex of the left mandibular canal. And later, once this implant was placed intraorally, we obtained the post-operative CBCT scan. And in the post-operative CBCT scan, this is how the implant is placed, exactly where we had originally envisioned it to be. We wanted it to be about 2 millimeters away from the superior cortex. You can see that very clearly it is about 2 millimeters away from the superior cortex of the left mandibular canal. Now this is the buccolingual section of the same patient, where we had planned it such that it will just be very close to the lingual cortex, yet not contacting the lingual cortex. It is very close to the buccal cortex here, but it's not perforating through the buccal cortex. This is how the image is obtained. You can see that it is lying very close to the lingual cortex, but not exactly touching the lingual cortex. And the same way, the way it was planned here, it's overlapping the buccal cortex, but not perforating it. So what are the advantages that we have for guided surgeries? There are hordes of articles in the index literature now that the placement is very precise, and if at all there is some discrepancy, of course there will be some discrepancy, but it is found to be less than 1 millimeter. It preserves all of the anatomic structures which are there, and the geometrical accuracy was found to be maximum. Because of the shorter treatment times and shorter surgery times, it is showing better healing because it is less invasive. As I showed you in the previous picture, the healing is very better, and the post-operative strain on both the patient and the dentist is highly reduced when a guided surgery is performed. So let's go through a quick checklist that can be done for patients with guided surgeries. The first one is of paramount importance, the clinical examination and choosing the right case for guided surgery. Then to obtain an intraoral digital scan, also known as the digital impression. Once that is done, that DICOM data is stored. Then a CBCT scan is obtained. Now the CBCT scan, it's preferable that you inform the CBCT scan center that this is for a guided surgery, and the preferred format has to be multi-DICOM format. Now, multi-DICOM format, the DICOM format is a standardized format. The output from a CBCT machine can be in a multi-DICOM format. There are multiple DICOM files, or a uni-DICOM format where a single DICOM file is there. But for the guided surgery, we would prefer it to be a multi-DICOM format. Both these data in the multi-DICOM format from the CBCT scan and from the intraoral digital scan are then transmitted to the laboratory. In the laboratory, the virtual planning is done on Exoplan software like Dr. Swapnil demonstrated. That virtual planning will then be sent to you. The approval has to be done by the implantologist. Once the approval is received by the laboratory, we then do the 3D printing of the guide. Once the 3D printing of the guide is done, that guide is delivered to the implantologist. The implantologist then goes about performing the surgical procedure. And then for the purposes of verification, you may also obtain a post-operative CBCT scan. Once you see that the implant is in the perfect position that was desired as was planned, if that is suitable, then either an immediate loading for the processes can be done or a delayed loading can be done as per your clinical judgment and decision. Now, there are various other modalities or possibilities, such as during the case selection, there can be a completely edentulous jaw, there can be a partially edentulous jaw, which has an opposing processes. Lot of such combinations or permutations can happen in the particular cases that we have. Today, we are not focusing on those particular cases because this was a brief overview of the entire process is what we wanted to demonstrate to you, how it starts when the case is selected, what do we do with the CBCT scan, what do we do with the intraoral scan, and then what exactly happens in the merging, and then how the guide is designed and printed out and then used in the clinical setup. But this is not a very hard and fast rule for every case. Some modifications will be there in particular cases. Those will be better explained when you have those particular cases, and if you would like to discuss it with us, you can send us those and then we can do it. And also we'll do those detailed ones in our future webinars, wherein Dr. Swapnil can take few particular cases and then he will demonstrate. But this is a brief overview is what we have tried to incorporate today. Now, this is something that I would like to say on behalf of myself and Dr. Swapnil that we have been using this and we have been using this to great efficiency in our practice, and we would really like you to try it out. Don't take our words for it just because he or I are telling you this, because we are fascinated by this. No, should be the one who uses this in your practice, and if you find the validity of it, then you would be more inclined to using it. So I would recommend that you try it in a few cases, 4 or 5 cases, and by then you would be pretty much confident, is what we have seen in our experience dealing with experienced as well as especially implant clinicians. So in conclusion, I would like to say that it does not matter how many resources we have, but we should use them correctly. Like this man here, he has a lot of ladders, but he's not able to climb over the wall and see what he wants to see. We have all these tools that are available with us right now, and we are at par with the rest of the world. And the best person to tell you about all of this, I would like to invite our senior colleague, Dr. Dinesh Jain, who's been an implantologist for the past nearly 4 decades. And he has been using guided surgeries as well in his practice for nearly about a decade now. And he has a wealth of information about the type of advantages that he has faced using guides, as well as the limitations that he may have said. And I would like to invite Dr. Jain to give us a brief clinical overview as to your experience on having used 3D printed surgical guides.
Hello, good evening, friends. This is Dr. Dinesh Jain. Am I audible, Manish?
Yes, sir,
Is that,
you are.
yeah?
Yes, sir.
Okay.
Yes, sir.
Thank you very much, Swapnil and Dr. Ajay. I think you very, very wonderfully explained everything step by step for this particular kind of a dentate case, where it's not a complete edentulous, but a partial edentulous case, where there were some colleagues who were asking about how do you mark those points. In a dentate case, it becomes much easier because you have the teeth, which are actually what you need is the radio opaque points for you to merge on of the CBCT data with the intraoral side. So that's very easy. But how you do in a complete edentulous, which probably, as Dr. Ajay has already mentioned, so that's the one thing point which I would like to add. Second thing, all these are again technologies. Dental Ceramists is known to bring in a lot of technologies, but the technologies again still require a human touch. So my experience with implant dentistry, which of course Ajay said 40 years, but I'm into practice from 1991. That's been about 30 plus years in implant practice, and we were amongst the first group of doctors who did go for a lot of implant training, and then eventually we started practicing. And as we grew, we realized that all these technologies are really playing a big role in fine-tuning our workflow. So after the freehand placement and all that, and then we could really look into these technologies to make work much, much simpler, easier, and less of a stress on yourself while you start with a case. So to begin with, I think anybody who has never done it, you need to, of course, just get yourself a little more comfortable by using the software, taking assistance from some of our colleagues, understanding, plan it yourself so you know exactly how you intended to place those implants. And then once the guide is fabricated, it becomes very easy. You know exactly how you had planned and how you are going ahead with it. So that makes your workflow very, very stress-free, because I understand that whenever we go ahead with this kind of situations, we would like to have as less a stress as possible and still give very fine results to the patients. This is what we are talking about, is the aspect of placement of implants in most ideal situation possible for the teeth to be. So it's like the placement of implant, keeping the ideal position of the teeth in place. But there could, of course, be situations where you may not be able to achieve it. But those individual situations would require a more detailed planning along with the software, where you can really plan keeping all those other limitations in mind. So if there are, of course, there are some questions which I did see regarding the data, whether you get the same data from all the machines. Well, all the medical devices, they have only one single format, and that's called DICOM format. So they're all compatible with each other. I don't think there is any other. So this has been standardized all over the machine. So the machines really do not matter. It's the accuracy of the machine, which what they say, or a good machine where the size of these CBCT slices, the smaller the size slices, that could be as small as 125 micrometers or little less than that, but the data becomes much huge. So those are the ones which are more, can give you a far more accurate results with this kind of planning. I'm sure this will add a lot to your way of your practicing implant dentistry, and it'll give you one more tool in your hand to be able to perform your work in a much less stress-free, or in a much more, in the teeth or the occlusally driven implant placements. But yes, wherever there are queries, Ajay and Swapnil will be very happy to take you through and help you. I'm sure you'll have some more questions. You can certainly address it to either the WhatsApp messenger that we have, or you can mail it to Swapnil and or Ajay, including myself, which we would be very happy to answer your questions and queries. And in the same series, I am sure if there are more queries, we can take it to the next level in the next webinar, keeping in mind the interest of all the participants. Thank you very much. Thanks a lot, Ajay and Swapnil, both of you. Swapnil, it was a wonderful presentation from your side. Thank you.
Thank you, Dr. Jain. Thank you for giving us this clinical perspective, which would help our participants understand from the clinical scenario, given your experience using these surgical guides. I would like to tell the participants that if you have any queries regarding our laboratory aspect or the Exoplan software, you you can contact us on these first two email IDs, and anything regarding the CBCT aspect on the third email ID, which is mine. The first one is the email ID of our laboratory. The second one belongs to Dr. Swapnil Pande. The third one is my email